All, welcome to our ninth session. Today we have Dr. Sunitha Daniel taking a session on palliative care on non-cancerous illness for us. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes followed by 15 minutes of discussion. We can start our case presentation by 4 o'clock followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Dr. Sridevi.
Once again, thank you all for joining in for the next session of ECO. And I'm happy to introduce Dr. Sunitha, who is a good friend of Palliative India. And it's nice to see you here in the ECO platform, Sunitha. And Dr. Sunitha she has completed her MRCP from UK in palliative medicine. Years of experience in palliative medicine in UK, and she came to India, I think, few years back, right? We met at that time. And currently, she was working with Amrita for some time and now working with the General Hospital at Ernakulam. And welcome you. I know that this topic is, you have a really hang of this topic, non-cancer illness and palliative care. I'm so glad to hear from you. Welcome.
Thanks, Sridevi, and nice to see you again after a long time. And thanks, Palliative India, for inviting me to do one more session. So can I have the slides, please? Okay. So basically the session what we are hoping to do or cover is for the next 40 minutes about the non-cancer condition. Next slide, please. So objectives would be to understand why patients with non-malignant disease would benefit from palliative care, and how can you identify such patients. And this is being a very vast topic. It's not possible to go into detail of each diagnosis, but I'm hoping to touch base with these conditions like COPD, heart failure, HIV, dementia, other neurological conditions, end-stage kidney disease, major psychiatric illness, and frailty. Next slide. So before we start, we'll have a case presentation, just 2 slides about a case where we've got George, who's 81 years. He's a retired teacher. He lives with his wife, Susan. He has had dementia diagnosed 5 years ago, and now he's in deteriorating condition. He's now currently dependent on all the aspects of care. He's incontinent of urine and feces and has difficulty communicating. He is only able to walk about 2 to 3 steps. Next slide. And in the last 1 year of his life, he has been seen by a general physician, a neurologist, and a cardiologist. And he also had 3 admissions to hospital in the last 12 months for pneumonia. The last admission lasted about 4 weeks. So within that last 1 month, he had 3 admissions to hospital, and the last one was for 4 weeks. And after each episode, he did not recover back to the point he was at before. So he did not come back to the baseline. And unfortunately, the last admission, he died on a ventilator. So when you see that he has been seen by 3 different doctors, it's a point to notice he has not been seen by a palliative medicine physician, and which could explain why probably he died on a ventilator, because the advanced care planning was not done. And again, this is a classic case of dementia patients, and probably see a common disease trajectory that we might encounter in our day-to-day practice. Next slide, please. I think I'm sure you're all familiar with the age-old definition of palliative care or palliative medicine, where WHO defined in 2002 that it's an approach that improves the quality of life of patients and the families and the patients who are faced with the life-threatening illness. And how do we do that? Is by prevention and relief of suffering. And that is by early identification and impeccable assessment and treatment of pain and other problems like physical, psychosocial, and spiritual. So they have mentioned the diseases that we were conventionally used to cover was one that was life-threatening disease with a very poor prognosis, and the top of the list was cancer. Next slide, please. But now, quite recently, the definition has been having a serious change. So in 2018, the International Association for Hospice and Palliative Care has put forward a new definition where they have suggested that palliative care should be a specialty that covers serious health-related suffering, which can be due to any severe illness, and especially it's for those near end of life. But we should also look for the suffering in more conditions than just cancer or the in the conventional conditions that we have always thought palliative care was involved. And we still aim to improve the quality of life of patients, families, and their caregivers. Next slide, please. They've also gone on to list the conditions which will have some serious health-related suffering and which will benefit from palliative care. So the cancer is still there. So malignant neoplasm cancer is still there, but you can see things like atherosclerosis, ischemic heart disease, dementia, degeneration of the CNS. You can also have hemorrhagic fevers, HIV disease, injury, poisoning, leukemia, renal failure, tuberculosis. So it's surprising that we have got some infectious disease also into the list, where it's believed that at any one point of their disease trajectory, they could be having a serious health-related suffering. So the other thing to notice about this list is, you'll learn to realize that this is more for a low and middle income countries. All these conditions, some of the conditions are more in a low and middle income countries, including India. So that is why this new definition of palliative care is more important to us, and we need to work on that to increase our reach for the population. And I believe that we still only less than 2% of our population has access to palliative care services. So that's very, very, we've got a big challenge in front of us. Next slide, please. Now, this graph shows how the scope of the serious health-related suffering is going to change from 2016 to 2060. So, if you look at, and this is the countries are divided according to the World Bank income regions. So, the shade that is in dark green are the low-income countries, and what you can see that is that what we believe is that the serious health-related suffering in the low-income countries is going to increase up to by 155%. As compared to high-income countries, where the number of serious health-related suffering is going to increase only at 57%. So that means that we've got a great challenge in front of us, because we're going to have a large number of patients with serious health-related suffering needing palliative care. And we belong to the low and middle-income countries, and where the challenge is about 87%. There will be an 87% rise in the number of cases with SHS when we reach 2060. Next slide, please. This is similar to what I said before. So it just goes by the number of the diagnosis. So the thing to understand from this slide is the number of death. The x-axis shows the number of death in millions with serious health-related suffering, and y-axis is the diagnosis. So what we can say is, and 2016, the blue color is 2016 and red color is 2060. So as expected, the cancer burden is going to increase. So the number of deaths per year due to cancer is again going to be high in 2060 as compared to 2016. Similarly, cerebral vascular disease, the number is going to increase. Lung disease, dementia, and liver is going to increase. But all the other conditions, what we are expecting is the number of deaths because of that is going to remain stable. So we're not going to see an increase in the number of deaths due to these conditions. Next slide, please. Yeah, this slide shows what is the cause of death worldwide, depending on from again 1990 to 2017. So as you can see that the blue bit is the non-communicable diseases, the red bit is the communicable disease, maternal, neonatal, and the nutritional diseases, and the yellow bit is the injuries. So you can see that the non-communicable diseases, the blue bit, the non-communicable disease, the number is going up as we travel from 1990 to 2017. The number of cases of the deaths because of NCDs have gone up as compared to the other communicable diseases. At least in developed countries, the communicable disease number has come down. So next slide, please. Now this bit is the same thing with India. So you can see that the percentage of the communicable disease was quite high in 1990s in India. The rate was quite high. We are managing to bring it down. We still haven't brought it down as developed countries. But in our condition also, in our case also, the NCDs is also going up. So for us, the challenge is both the communicable disease and the non-communicable disease. Next slide, please. Again, this is a current disease burden in our country. So the challenge that we are facing is, we all know that our living conditions are changing. There are some, at least in Kerala, where it's a high health index is there. It's like similar to Western population. So living conditions are changing, and on top of that, we've got unhealthy eating, excess alcohol, physical inactivity, and tobacco use. But the sad part is, we still haven't been able to to control our communicable disease. We still have got this dengue and hemorrhagic fevers, all rainy seasons. We still got cases of malaria. So we still haven't been able to control the communicable disease, and we have to face a burden of non-communicable disease, which unfortunately starts as a younger age group. So there's a challenge with the prevention strategies is a great challenge. Long-term care, once you've got the disease, and the great challenge. And what all conditions we have to face? We've got cancer, we've got cardiovascular diseases, the chronic respiratory disease, and diabetes. So 32% of all the deaths in rural India is now because of NCDs. Next slide, please. This is a report that came from the India State Level Disease Burden Initiative from ICMR in 2017. Said that 40 to 75% of diseases in the country are because of NCDs. Next slide. Now, so we all know that both cancer and non-cancer needs access to palliative care. But then this study was done in it's a retrospective study which is done in a community and hospital palliative care provision, a large UK city. So UK, as we all know, is where the palliative care or palliative medicine developed as a specialty for the first time. And this study was done in a large UK city. Basically was trying to find out what was the time of referral to palliative care services of a patient in the community and the hospital. Next slide, please. So we retrospectively audited about 4,650 patients in the analysis, of which about 3,000 had diagnosis of cancer and 747 had diagnosis of non-cancer. And the median duration of palliative care for the whole study population was 37 days. That is, we found their time of the date of death, and we found the day from which they were referred to palliative care specialty. And the median, so they were just found that they were referred to palliative care for the median time was about 34 days before they died. And in cancer, it was 37 days, slightly higher than the median time. Non-cancer, it was only 16 days. Whatever research that we have, or the ASCO guidelines have said that we need at least the optimal referral to palliative care should be at least 6 months before death. At least people are going for 1 year before death and using surprise questions and all. I'll mention surprise question towards the end of the presentation. But the sad state is, even in the countries like United Kingdom, where the palliative care is much developed, the non-cancer patients are only seen 16 days before they die. Next slide, please. Now, why is it important? Why is it important for non-cancer also to get palliative care? So we all know about the symptom management that we cover for cancer patients, and what are the symptoms that we look for in cancer patients. Now, in JPSM, there was a comparison of the symptom prevalence of advanced cancer, and they compared that with AIDS, heart diseases, chronic obstructive pulmonary disease, and renal disease. And they found that the three symptoms, that is pain, breathlessness, and fatigue, was found among more than 50% of patients for all the 5 diseases. So it is a very, very prevalent. All these 3 symptoms are very, very prevalent in non-cancer cases also. Next slide. This is a table that shows how much of percentage of symptoms are there for all the other symptoms there for all these conditions. So we mentioned pain, breathlessness. Now fatigue, about 32 to 90%. There's a wide range of cancer patients complain of fatigue. Similarly, COPD patients of the 68 to 80% are fatigued. Depression, again 3 to 77 for cancer. 37 to 71 for COPD patients. If you look at breathlessness, the important thing is only 10 to 70 for cancer, but obviously COPD 90 to 95%. Very, very large amount of patients are breathless. And because they don't have a label of lung cancer, they wouldn't be seen by a palliative care doctor, because nobody knows that we can see non-cancer patients also. So they are all going to die with intractable breathlessness because we're not getting involved. So, and anorexia, 30 to 92 in cancer patients, and COPD patient 35 to 67. So it's all the symptoms that we commonly deal with in cancer patients. All the non-cancer, most non-cancer conditions, at least in the end stage, have got these symptoms. Next slide, please. Continuing with the same paper, what we've found is, all these conditions, when they reach advanced progressive stage, they've got a common pathway to death for all the people with advanced progressive diseases. And so that means that palliative care is very relevant for all the 5 conditions. although the aspects of assessment and management may be different. So basically, when do we start seeing them? What all do we do for them? We might, when they get a first chest infection and come to hospital, we might think of doing things like active management, giving antibiotics, all those things. So that aspects of management might be different as compared to cancer patients. So each one you have to take as individual basis, discussions with the family, ongoing discussion with the family, but still the pathway is still the same. Once they reach the advanced end stage case, they behave similar to cancer patients also. Next slide. So the first condition, so COPD. Now there was some study done in thorax where we were trying to find out how well do we care for patients with end stage COPD, and the comparison of palliative care and quality of life in COPD and lung cancer. So the two major ones of respiratory illness, the COPD and lung cancer. We did a comparison of what's the quality of life and palliative care of patients with having COPD and having an end stage lung cancer. What we found that patients with COPD were scoring significantly worse than those with an inoperable lung cancer. What did we look for? We looked for activities of daily living, ADLs, their physical functioning, emotional functioning, and social functioning. And unfortunately, the COPD patients were scoring worse than the patients with lung cancer. And as I said in the previous slide, patients with non-malignant diseases were more troubled by breathlessness, 94% versus 78% of cancer patients. Next slide. But none of those COPD patients, the same article told that none of the COPD patients received any special palliative care services. Now this was in 2000, so that at that time it is most probably unheard of providing palliative care for non-cancer conditions, because we all know that it started with a cancer specialty. So none of the COPD patients in that study had received any specialist palliative care services. Next slide. Now, when the question was asked about whether you want a comfort-based care and did not want ventilation, when you ask the same question to a cancer population and the same question to a COPD population, the similar proportion of the two groups of patients wanted comfort-based care, more than 60%, and 80% did not want ventilation. But what the evidence suggests that about most COPD patients receive ventilation, 70% versus 20%. And we all know that once COPD reaches an end-stage condition, if you do an invasive ventilation, they're very, very unlikely to come out of the ventilator. Obviously, things have changed, and we've got non-invasive ventilations and BiPAP ventilation now, so people do live longer. With the BiPAP, they do manage things at home, so that is a different story. But when you go into non-invasive ventilation, it's very, very difficult for them to come out of the ventilator support, and they are invariably going to die in a ventilator in the ICU, away from the family. And that has been ongoing for the COPD patients. Next slide. So how do we then manage patients? How do we manage patients with symptoms? At which point do we start? Now, this slide will tells us, so whenever we think of non-cancer conditions, right now what ASCO says and what the oncology people say is that actually oncology patients or cancer patients will benefit from the input of palliative care services at the point of diagnosis, at least in metastatic conditions. Now, even if it's not metastatic conditions, if they've got very bad pain, they would benefit from our input for pain management. Now, at which point do we enter into COPD services? So what the guidelines say is that initially, depending on the magnitude of dyspnea, we need to manage them. So always when we start at one end of the rectangle, we start all the pharmacological therapies that we give for a COPD patient. So obviously we know we put them on short-acting bronchodilators, long-acting anticholinergics, the inhaled corticosteroids, long-acting beta-2 agonist, the PDE4 inhibitors, theophylline, all these depending on the severity. So you don't start everything together. Once we diagnose COPD, step by step, you start all those measures. Now, we all know it's a progressive condition, and especially if they don't stop smoking, it is going to get worse. So the patient is going to go into the next step. And once they're on all the maximal, optimal management for COPD patients and they're still breathless, that's a point when we can actually start with the non-pharmacological therapies to manage breathlessness. Now, Cochrane has done literature review to find out what all therapies has got evidence-based, and what they found is exercise, walking aids, chest wall vibration, and NMES, neuromuscular electrical stimulations, are the non-pharmacological mechanisms or non-pharmacological methods that can actually improve the breathlessness. However, there are lots of other stuff that we can still do, which so far doesn't have Cochrane-based. So Cochrane obviously goes to all the randomized control trials and bring forward the evidence-based medicines. But there are lots of respiratory exercises and handheld fan, use of handheld fan for non-pharmacological management breathlessness. We teach patients about, personal breathing is mentioned there. We teach patients about how to control their breathing. The 3 F's of rescue breathing, things like breathe a rectangle, then calming hand, which is something like, all this should be covered in the non-pharmacology management breathlessness. So all these have got some evidence, even though it's not Cochrane evidence, for managed breathlessness. And the typical palliative medicine MDT team, the respiratory physiotherapists should be able to train the patients how to do all these when they get the referral. So a palliative medicine specialty has got an important role in the non-pharmacological management breathlessness if the patients are referred at that point. And these patients will still have got at least months to live because they're still on the optimum therapeutic management for COPD. Now, once that is all started and then still the condition is getting better, then we go into the opioid therapy. So we put them on morphine, low-dose morphine for breathlessness, and depending on the amount of SOS medications they need, you can actually start them on long-acting opioid therapy. So that's how we manage patients, and then obviously we keep them on regular follow-up and assessment, and then they go into a end-of-life stage where again we would have done the advanced care planning with the patient and the family, so hopefully we'll be able to provide a better end-of-life care for them. Next slide. Next condition is the heart failure. So again, UK data states that heart failure, the incidence of heart failure in the UK is about 1 per 1,000 population per year. Now, studies have shown that survival rate with the heart failure is worse than breast and prostate cancer. So breast and prostate cancer, if they are detected early on, they actually do better. So even though the patient has got a cancer diagnosis, they might do better than a heart failure patient. What they found is half the patients who diagnosed the heart failure die within 5 years of the first hospital admission. So again, there's evidence to show that half of the patients, 50% of patients, after the first hospital admission, within 5 years, they die with a heart failure. And between 1/3 and 1/2 the patients die suddenly irrespective of heart failure stage. So that is again because all the arrhythmias involved. These patients are more prone for sudden cardiac death. They might not be in the NYHA stage 4 stage yet, but they still have more prone for sudden cardiac death. So that is again, it's a very important thing to do advanced care planning for them. So that is because of the sudden death rate, it's important for the discussion of preferences for care from the time of initial diagnosis for these patients. Next slide. This slide shows you how do we classify the patients depending on the NYHA heart failure classification and the ACA classification, American College of Cardiology. You must be familiar with this slide. So basically, normally when we say this end stage heart failure, we usually go for NYHA class 3 to 4. So it says that there'll be a marked limitation of physical activity that is in class 3, and in class 4, they're unable to carry out any physical activity without discomfort, and that is an AHA or American Heart Association stage D cancer, which means that there's a presence of advanced heart disease with continued heart failure and symptoms requiring aggressive medical therapy. And usually we get involved in 3 and 4. Next slide. These are the potential medications that could be started at different stages of the heart failure. Now, obviously, when we get involved, these patients would be on all these medications because a cardiologist would have started that. But for us, if we are managing patients with end-stage heart failure, it will be useful for us to know that, to make sure they're on all these medications. And if it is not started, we could probably add on to it. So you've got diuretic, which can be started from NYHA 2 and continue till class 4. ACE inhibitor should be started from class 1 and continue till class 4, and it has got improved survival benefit, as well as it will decrease the hospital admissions and improve the functional status. Beta blockers again has a role from throughout the diagnosis. Mineralocorticoid antagonists, we can start from class 2 and continue to class 4. and digoxin is only from class 3 and class 4. And all these, except digoxin and diuretics, seem to improve the survival of the patients and also decrease the hospital admissions and improve the functional status. So again, this is something that we need to remember when we you all know that when we take over patient, we do things like rationalizing medication. So it's sometimes not straightforward rationalizing medications of patients who have got end-stage heart failure, because tablet burden might be an issue. Obviously, the cholesterol tablets are not there. Cholesterol tablets are something that we always stop immediately when we get the patient, which is fine. But all these cardiac medications still have a role, even if they are in NYHA class 4, to improve their functional status. So if we have to rationalize medication for like things like if the BP is falling, then obviously we'll have to do a risk benefit thing. But always keep in mind of all these cardinal medications before we stop anything. Next slide, please. Third condition, the end-stage kidney disease, and I think it's our case presentation is also on end-stage kidney disease. It's quite, I think we have more discussion at that point also. So who are those patients who would benefit from palliative care who's got end-stage kidney disease? Those who choose or advise not to start on dialysis. Now, again, probably not very straightforward in our scenario, because I'm not sure whether any renal physicians will even have a conversation with the family about the fact that there is an option of not going for dialysis. So once you reach end-stage heart failure, end-stage kidney disease, then the only option that we or the renal physicians will give the patient is just dialysis. There is not a route of no dialysis. But in next slide I'll show you a study that done again in UK about how they manage patients who didn't go into dialysis route. So the patients who would benefit from palliative care is those who are advised. They did not choose for a dialysis. They go for conservative non-dialytic management. Now, if they go on dialysis and they fail to thrive, they don't show any improvement, and who experience a worsening quality of life and increasing symptom burden despite dialysis, then probably you may not stop the dialysis immediately, but you can add palliative care to that. And third one is those who discontinue dialysis. Then obviously we need to give them palliative care at that point. Next slide. Now, it's seen that end-stage kidney disease have an extremely poor quality of life, and they need frequent hospitalizations and prognosis comparable to that of a common malignancies. Now, it's not just hospitalization; it's dialysis twice a week, thrice a week. Once we had a presentation in UK, and there's a cartoon of a person who's wearing all dressed up on a Santa outfit, and he's sitting there. So it looks like it's a Christmas day, and he's getting his dialysis, and he was looking very, very grumpy. And the nurse was telling, it doesn't matter which day it is, you're having it done. So basically, that is what happens to dialysis patients. They are in hospital. They, sort of stays in the hospital. So and then on top of that, they have any complication, they end up coming to hospital. So dyspnea, confusion, pain, anxiety, and depression are very common during the last few days of life. Next slide.
Dr. Sunitha, are you there?
I think, Raju, we need to call her.
Yes, ma'am, I will be calling her.
Some network issue, I guess.
I'm sorry, my power went off. Yes, we're having floods. We're having very bad rain again. Can you? I'm using my data now. Am I audible?
Yes, ma'am, you are.
Okay. So I'm hoping the data will hold. It's Wi-Fi has come back, but I'll carry on with this. So this was a retrospective observational study. This was done on patients with advanced chronic kidney disease, and it was done to compare the survival, the hospital admissions, and palliative care access of the patients more than 70 years who had a CKD stage 5 diagnosis. So these patients, they had a common clinic they had a clinic where it was seen by a renal physician was there, and there was a palliative medicine physician also. And these patients, more than 70 years, were offered either to go into dialysis stage or go into conservative management, both the arms. And then this study was done on those patients. And it was found that the patients who were aged more than 80 years with a poor performance status or high comorbidity scores, the renal replacement therapy or dialysis didn't have any survival advantage over conservative management. That means the patients who went for conservative management actually lived longer than those that went for dialysis in patients who are more than 80 years. Okay, it's elderly group anyway. And obviously, the conservative management part will give you greater access to palliative care services, and we're less likely to be admitted or die in the hospital. Next slide, please. Next condition, AIDS or HIV. Now we all know that when HIV first came into into the picture, it was like a death sentence, and palliative care was only given during end of life. Now recently with the antiretroviral therapy, heart has come into the picture. There's a changing epidemic, and it's the patients who's got diagnosis of AIDS can have a near normal life expectancy. Next slide. This is a slide which shows the trajectory of chronic illness over the time. So the one that is in a complete line is a cancer or the pre-heart AIDS, but similar to the cancer. So you get a diagnosis, you go on, and then you get a diagnosis of cancer heart, and then you dip quickly and you come down and you die quickly. The broken line graph is actually all the other chronic conditions like congestive heart failure. And now the AIDS in the heart area is also treated as a condition like that. So where you go, your disease, as disease progresses, your condition deteriorates, you have a very bad infection, or you get admitted to hospital, there's a dip in the condition, then you come back and then you become normal, you go on for some time, and the dip comes. So gradually the dip worsens, and finally you you die. So end of life is sort of prolonged in that. And that is the situation for all the non-cancer conditions, and AIDS in the heart era is also behaving like that. Next slide, please. Next slide.
Ma'am, we have changed the slide. Can you see it?
Can you hear me, Rajlakshmi?
Yes, ma'am. Can you see the slide, ma'am?
Okay. So how does palliative care work for HIV or AIDS complex? How does it affect? So or what are the palliative care needs of AIDS patients? So you can see that HIV infection, it can cause chronic immunodeficiency and inflammations. So they can have recurrent infections. They can also have the non-AIDS specific comorbidities, like you can have non-AIDS defining malignancies. You can have, like any other patients, you can have
I think we lost her again. We'll wait for a few seconds. I think there is a terrible rain happening in Kerala.
Yes, ma'am. There is.
We'll just wait for a few seconds.
We can wait for a couple of seconds. I think she will be redogging in again.
Raj, you want to call for it?
I have sent a message, ma'am. I hope.
I think you may need to call her because messages won't be delivered if there is no internet.
She replied that she's trying logging in.
फोन लोग चाहिए मरा
Ma'am, we are trying to. I think she will be there. Or should we start with our case presentation and then come back to presentation?
हेलो
Device to start with the case presentation.
So can we start with case presentation now?
No, I thought she might have read through the case presentation, right?
Yes, she have read it.
Okay. What do the others say? Will it be okay to start with the case presentation?
Yeah.
Yeah, Raju, who's present? Just tell Dr. Sunitha that we are starting with the case presentation.
I think we can start with the case presentation.
Raju, can we start the case presentation? Dr. Jyoti is presenting today.
Yes, ma'am, we can start case presentation. Dr. Jyoti?
Yes.
Yes, ma'am. You can continue.
I am Sister Jyoti, belongs to the congregation of St. Anne's of Providence. I completed my MBBS and MS in General Surgery from St. John's Medical College, Bangalore. Right now, I am working in St. Martin the Porres Hospital, Isanagar, Bilaspur, Rampur district, Uttar Pradesh. It is a 15-bedded hospital in a rural setup. I take care of all the patients. Not only I do less of surgeries, but all general. I take care of all general patients. We have for today's presentation, lady with 50 years old, female, with chronic renal failure, hepatitis C infection, diabetes mellitus, hypertension with hypoglycemia. She presented to our emergency with loss of consciousness since 1 hour, constipation since 10 days, decreased urine output since 15 days, swelling of body since 25 days. She's known diabetic since 15 years, hepatitis C infection since 5 years, hypertensive since 4 years, and diagnosed to have renal failure 5 months ago on irregular treatment, presented with loss of consciousness since 1 hour. Patient was conscious 2 hours ago when her son had gone to give the dinner. He found that she was not responding and brought to the hospital. She had loss of appetite and unable to eat since 10 days. They had stopped oral hypoglycemic since then. Her RBS in glucometer was 26. She responded to 100 ml of 25% glucose. Constipation since 10 days, hardly anything she had taken for the past 10 days. She was advised to take proctoclysis enema, but she had not taken. Swelling of body since 25 days and decreased urine output since 15 days. Diagnosed to have renal failure 5 months ago, received dialysis on alternate days in Ramurthy Medical College Hospital, Bareilly for 1 month, 4 months ago, which is 77 kilometers away. Advised to come for regular dialysis twice a week. She had gone only once for follow-up and dialysis. Due to financial problem, they were unable to go for regular dialysis. Her urine output decreased to about 200 ml per day. She is in bed and unable to walk about. She feels very weak and tired. On examination, she is pale and generalized edema present, no icterus, cyanosis, or lymphadenopathy. Her pulse rate was 90 per minute, feeble. BP was 160 by 100. She is conscious after giving 25% of glucose. She is oriented. Systemic examination, respiratory system, bilateral scattered crepes were present. Cardiovascular system, there were normal heart sounds and no murmurs. For abdomen, no organomegaly, but mild ascites was present. CNSS examination was normal. Five months ago, when she was admitted to a hospital with nausea, vomiting, fatigue, and breathlessness, she was diagnosed with renal failure and was referred to the tertiary care hospital. She was taken to 4 hospitals before she could go to Ramurthy Medical College, Bareilly, where she received regular dialysis. All the expenses were met by the parish priest. After 1 month, she was discharged and was advised to come for dialysis, but she did not go for any follow-up due to financial problems. Her investigation, hemoglobin was 8 gram percent, serum creatinine 6 mg per deciliter, RBS at this time with glucometer was 26. She is HCV positive, hepatitis B and HIV was negative. Her psychosocial aspect, she lives with her husband, 4 daughters and 1 son. 1 daughter is married, 1 is working and 2 are studying in the boarding. Son was working in the factory. Husband is a laborer. Daughter left her job and staying home to cook. Son was irregular for his work, so he lost his job. Husband hardly goes for any work. So they are in financial crisis, and therefore it is very difficult for her to go for regular dialysis. Therapist had taken care of all expenses during her outside hospital stay. Whenever she was admitted in a hospital 4 to 6 times with different complaints, and all her treatment in the hospital was at free of cost. She was worried about her health and children since they were not settled. I had explained about her condition and prognosis to her husband and children. I had also told her that she has to keep herself ready for anything. She was all the time anxious, and for all her complaints, they would bring her to the hospital. She was she was started on tab cardiovas OD, tab nexovas OD, and tab aten OD from outside hospital, and was advised on renal diet and hypoglycemic. Oral hypoglycemic she had stopped since she was not able to take her oral feeds. Her main concern was fear of what will happen to the settling of the children, anxiety, financial problems. To summarize, 50-year-old lady with chronic renal failure, not on dialysis, hepatitis C infection, hypertension, diabetes mellitus with hypoglycemia. For discussion, I have taken these points. In renal failure, when we are unable to go for dialysis due to financial problem, what can be done? How can we prepare for her for end of life? How can we convince her relatives for home-based care?
Thank you, Dr. Jyoti. I think we'll keep the discussion points like this. If Dr. Sunitha is back, we can continue the presentation, and once after the presentation, we'll go on to the discussion points again.
Okay. Hello, can you hear me?
Yes, yes.
I'm really sorry about that. Something wrong with my access. I'm doing it through mobile now. So we are in the palliative of HIV. What are the other issues? So one is the non-AIDS specific comorbidities, then the drug toxicity. So all the medications, heart medications can have its own toxicities, renal, hepatic, metabolic toxicities and drug interactions. Then the psychosocial issues. So these patients who have HIV diagnosis, it's likely that they could be having some issues of substance abuse or mental health problems and social isolations more than the other cohort of patients. And so you have to do advanced planning for them for chronic disease and the other environmental stresses like poverty, unstable housing, unsafe environment. So all these shows that there's an increasing need for multidisciplinary and chronic care management, and which is the centrality of palliative care. Next slide, please. Next, we move on to advancing dementia. Next slide. Okay, so they've done the prevalence of various symptoms of advancing dementia. What all can we expect is, as usual, as we all know, confusion tops the list. 83% of patients with advancing dementia are confused. They can have urinary incontinence, then pain, low mood, constipation, and loss of appetite. Again, similar to the symptom profile that we can find in our classic palliative care patient of any diagnosis. Next slide. We've got this a summary of the functional assessment staging. Now, we have all probably heard of the mini mental state examination, or MMSE, where we make a diagnosis of dementia. So depending on the depending on the scoring, you can divide into mild cognitive impairment, moderate, and severe cognitive impairment. That will give us a diagnosis of dementia. Now, this FAST scale, it's one of the commonly used global measures for staging. Now, others include you have something called a clinical dementia rating scale, or CDR scale. Then you've got a global deterioration scale, or GDS scale, and there's a FAST scale. So basically, it's self-explanatory. You stage the patient depending on what all they can do or not able to do. So stage 1, there's no subjective or objective difficulties, and if you come to stage 7, where there's A, B, C, D up to F. So speech is limited to less than 6 words per day or 1 or less. The inability to move around independently, inability to sit up without assistance, smile, and hold the head up. So depending on what all they can do. So once they reach the 7F stage, they are sort of reaching into the end stage, end of life scenario of a dementia patient. So that's how we identify how the disease is progressing. Next slide, please. What all can we do in advancing dementia? Interventions that we can do, the topmost on the list is advanced care planning, where once you have a diagnosis of mild cognitive impairment, or once we know that they're going to dementia stage, we need to have discussions about what all do we do if the things go wrong. So issues about feeding, issues about antibiotics for chest infection, issues about hospital admissions, where do they want to die, all those comes in the advanced care planning. And we have to have discussions about avoiding any potentially burdensome treatments. Should we refer them to a nursing home, to a hospice referral, and the support that we need to give to the caregivers, because the caregivers, it's the prognosis is quite unpredictable. They probably can live on for some time with the symptoms of dementia. So caregivers will need a lot of support to manage such patients. Next slide, please. Just mentioning the other neurological conditions other than dementia. So you've got motor neuron disease or amyotrophic lateral sclerosis, Parkinsonian syndrome, multiple sclerosis, ischemic and hemorrhagic stroke. Again, progression of all these diseases will need palliative care at least towards the end of life. Next slide. I've got two slides about what are the symptom management issues you can face in any neurodegenerative conditions, and what do you do for that. So you've got constipation, we manage with all the laxatives in that just like any other constipation. So you've got osmotic and stimulant laxatives, and dyspnea, opioids, anxiety. You can give lorazepam. It's fast-acting and anxiolytic. You can even start midazolam at end of life. Fatigue, you can try SSRIs like citalopram or any psychostimulant. Muscle cramps, quinine sulfate. Pain, again, pain, we have to be a bit cautious about starting opioids straight away. So you can start with, depending on the type and the cause of pain, you can start weak opioids like tramadol and tapentadol. If it's like a spasmodic pain, you manage it accordingly. And if it's a neuropathic pain, then you give antidepressants. If the pseudobulbar effect, first choice is dextromethorphan or quinidine, and you can also give them SSRI. Next slide. Some patients can have pseudo hypersalivation, so increased secretions. You can give some anticholinergics for that, including amitriptyline and buscofan or hyoscine hydrobromide. Psychosis, agitation, irritability are managed with quetiapine. Or try and give them a calm and stable environment. Sleep disorders, you can try clonazepam and melatonin. Respiratory failure and NIV. Again, that is depending on the different patients. So whom do we send for? That's part of advanced care planning. So are they for NIV? Can they afford that? Are we able to send them home on NIV? Are we able to loan the patient with NIV? Issues about tracheostomy. And you can even try morphine for symptomatic breathlessness. And if it's Parkinson's with the rigidity, bradycardia, and akinesia, you can go for medications accordingly. Next slide. Further, I've got sleep insomnia, so soproquolone, amitriptyline, mirtazapine, spasticity, baclofen, tizanidine, and secretions, if they're quite thick, you can give things like mucolytics. So the secretions can be either thin secretions or thick secretions. Thick secretions, we give mucolytis to bring it out, and nebulized saline, and teach them how to do the manually assisted cough techniques and modified postural drainage and humidification. Next slide. Other important entities, what we call as a frailty in old age. So there's an increasing number of geriatric patients now, and it's predicted that by 2050, about 16% of world population will be over 65, and which is about 1.5 billion compared to in 1950 to only 5%. So advancing medical technology, people are living longer, and frailty is where the elderly people, they've got diminishing capacity to withstand any stress. Basically, they'll have increased vulnerability to adverse outcomes, and they have physical disability, and they'll have impairment of all the activities of daily living. They'll be socially withdrawn, slow motor processing, cognitive changes, weight loss, and negative energy balance. Next slide. What are the implications? So when you diagnose a patient with frailty, what's going to happen? Why is it important? So people have diagnosed a raised stage of frailty. They've got increased risk of falling. We all know the geriatric giants that falls and postal hypertension and infections like UTI. So there's an increased risk of falling for these patients. If there are hospital admissions, there'll be reduced activities of daily living and disability. Now, it is seen that in death, about 3 to 5% of deaths in older adults could be delayed if frailty was prevented. So all the patients don't reach into a frailty stage. So it's seen that about 3 to 5% death of older adults could be delayed if frailty can be prevented. Next slide. So how do you prevent frailty? We all do this actually. So primary prevention is basically to address a comorbid illness like hypertension. The secondary preventions like the other chronic disease management, but then also teach them about exercise and nutrition, which is very important. Deconditioning. If you don't exercise the muscles properly, they go into muscle wasting. So exercise is all very important, and nutrition. And tertiary prevention, obviously, is good palliative care. Maintain and improve the function, control the symptoms, and maintain the psychological well-being as well as prevent hospital admission. So try and manage things at home. It's seen that actually people, if you just got infections that you gain from the community, they do much better than going to hospital and getting a secondary infection from them. We all know that hospitals are notorious for all this hospital acute infections, which are obviously would be multi-drug resistant. So preventing hospital admissions. Next slide, please. Just 2 or 3 slides about major psychiatric illness. I'll only be mentioning about depression here. Depression is also very common in oncology patients. It's found that prevalence is 38%, and just depression in oncology. And prevalence of depression spectrum disorders is 58%, compared with the 6.6% of 12-month prevalence and 16.6% of lifetime prevalence in a general community. So the spectrum disorders of depression is more common or more prevalent in oncology compared to a general population. And the DSM has also got another diagnostic criteria where we can say that the patient has got a depressive disorder, not endogenous depression, but a depressive disorder that's associated with another diagnosis. So it can be because of the conditions like hypothyroidism, chronic uremia, or presence of cancer-induced cytokines, or medication efforts of chemotherapeutic agents. So when we add them both together, depression is very, very common in cancer patients. Next slide. What are the consequences of depression, cancer, or advanced disease? So what happens if you don't treat depression? It's found that untreated depression would definitely affect the compliance or treatment adherence. So patient has got reduced understanding about why they're taking any medications and why they should take it for. They have ambivalent decision making about palliative treatments. They don't have any motivation for care and any healthy behavior. They're not motivated to do that. They have pessimism about the outcome and benefit, poorer tolerance of side effects, poorer family support, lead to greater social isolation, and reduced use of the community resources. So all this will affect the treatment. Next slide. The National Comprehensive Net Resource Management suggests that, so we know that it's important, we know that it's prevalent, so it's important for us to screen our patients for depressions. And they've given some suggestions as to what all you can use. So that you can, if you've got things like Beck Depression Inventory, GHQ, the General Health Questionnaire 28, PHQ, the Patient Questionnaire. Also, the NCCN has given a distress thermometer. We can use any of these to assess whether the patient has got depression, or you can even use a single question. Are you depressed? What is your mood? Do you feel low in mood? That also is quite useful to know whether the patient is depressed or not. Next slide, please. We've also seen that we also know the discussions about euthanasia and physician-assisted suicide is quite it's common in the palliative care population. And the reason behind this is because all these add together. So they could be clinically depressed. They can have functional limitations. Their spiritual well-being could be affected. They can have other symptoms, pain and symptoms. All these add together. They feel demoralized. They feel that their life is meaningless and they are hopeless. There'll be lack of social support, and all these can increase the desire for death or the suicidal ideation or interest in the physician-assisted suicide in patients of having palliative care diagnosis. Next slide, please. We've seen that there's some Dutch studies which have shown that depressed patients are 4 times more likely to request euthanasia than those patients who are non-depressed. And a study done by cyclists found that 25% of patients in a palliative care program in Netherlands wanted to discuss euthanasia. And the reason why they won't discuss euthanasia was one was because of fear of process of dying. So they don't know what is exactly going to happen when they die. So they're afraid of death, so they will just end it quickly. Burnout, which is like demoralization, the need for control, depression, and poor symptom management. Now, most of this we can at least try and sort of address that. So mostly when patients say that they won't have euthanasia, it's because of all these unmet needs. That is why they end up asking for euthanasia. Next slide, please. There are 2 slides quickly about what all you can give for depression, and this is again covering all the related disorders in palliative care. So we all know amitriptyline, and you can use that for pain, insomnia, and depression. And you've got a range of 25 to 150. Usually for pain, we stop around 75 and go higher than that. You need higher doses for depression. SSRIs, you can try again for depression, anxiety, OCDs, and PTSD. The doses are given. The SNRI like venlafaxine, duloxetine, again severe depression, anxiety, you can use them for that. Dosage is given in the slide. Next slide, please. We've got a selective dopamine and noradrenaline reuptake inhibitors called bupropion. Again, it's indicated for depression, fatigue, dose of 150 to 450. The mirtazapine is a newer one, lesser side effect. Got lots of uses in palliative care. So depression, anxiety, appetite and weight gain, insomnia, range from mirtazapine 15 to 60 milligram. We've got trazodone, which is used for sleep and depression, dose again 50 to 300, and psychostimulants, usually indicated for people who have got a very short prognosis. They think they're very, very depressed because they're pretty quicker acting than the conventional antidepressants. So you can give methylphenidate or modafinil for depression and also for opioid sedation, sort of to wake them up. Next slide, please. Now, what are the barriers for identifying or for sending up? So I've sort of roughly covered all the conditions that comes in non-cancer diagnosis. Now, just to mention about the barriers that is usually identified of why the patients are not sent for a palliative diagnosis. One is the prognostic uncertainty. The physicians and the cardiologists said it's very difficult to identify the prognosis of heart failure patients. So they've done a study which came in palliative care for heart failure in British Medical Journal in 2002, when they found that patients with heart failure were predicted to have greater than 50% chance of survival for more than 6 months. The patients in the study were the patients who had supposed to have a greater than 50% chance of survival for more than 6 months, but they all died 3 days later. Next slide, please. So this is a graph we can just initially mentioned before. So you can see that it's so difficult to predict the prognosis. So the middle one shows the heart failure and the other chronic diseases patients. So all these dips that come down, the dips that come down in the trajectory, we all feel that the patient might be reaching end of life at that stage, but they come back and they come back to the baseline. So this goes on. So it's so difficult to actually predict when that last episode is going to be, and that is a problem that most doctors or physicians face because they can't identify the end of life, and that's why they don't refer them to palliative care. Next slide, please. What are the professional barriers? So not knowing how long the patients will live creates an uncertainty. It paralyzes the doctors and it potentially prevents them from taking palliative care, as I explained before. And again, we all, have, as doctors, has been treated to cure the patient and help them to live longer. So there's a natural desire among the physicians to be optimistic. And mention the word palliative is going to alarm the patients. So that they avoid mentioning the word palliative and therefore they don't refer them to palliative care. Next slide, please. Similar to that, it's the perception that death is a failure. So once you decide that your patient has got no further treatment, we feel that we have failed the patient. So medical perception that death is a failure. There are lack of skills and symptom control from the physician side. Lack of obviously specialized palliative care resources and evidence. We still haven't got enough to cover the poor population. So resources are not there. Some hospital policy about not referring to palliative care and lack of palliative care services. Next slide. What are the barriers from patient and family? So patient and family's perception would be, I don't have cancer, so why am I visiting a palliative care service? And failure to recognize as a terminal illness. Even an end-stage non-cancer condition can become terminal at one point, and that failure to recognize that. And the caregivers also have got unprepared to decide the transition from a life-sustaining to a comfort care, aggressive comfort care stage. Next slide, please. So how do we refer? When do we refer? How do we decide when to refer to palliative care? Next slide, please. This is a very interesting tool, the SPICT tool, which is supportive and palliative care indicator tool. Now, it's a guideline. It's a guide to identify the patients at risk of deteriorating health and dying. Now, assess these people for the unmet supportive and palliative care needs. So the box is general condition of the patient. So look for 2 or more general indicators for the deteriorating health. So one is a performance status. The performance status is very poor. That means the patient is in bed or chair more than 50% of the day, and there's limited reversibility. So they could be like that because of an infection, and they could come back. That is different situation. But in this scenario, the patient's always baseline is like that. They're more than 50% of the day they are in the bed or a chair, and there's limited reversibility. They're dependent on others for most of the care needs due to physical or mental health problems. 2 or more unplanned admissions in the past 6 months. Significant weight loss, persistent, troublesome symptoms despite optimal treatment of the underlying condition. So, end-stage COPD and all the maximal treatment that a respiratory physician has given them, but still they've got very, very bad uncontrolled symptoms. And the last one is patients asking for a supportive palliative care or treatment withdrawal. So these are the indications, general indications. If they've got 2 or more general indicators, and they have to be referred to a palliative care. Then it goes on to give us a specific indicators for advanced conditions. So it's a very useful tool. It gives a specific indication for cancer, for dementia, for neurological diseases, heart diseases, for respiratory diseases, for kidney disease and liver diseases. So all this, it's got a specific indications. And what it says is look for any clinical indicators of 1 or more advanced conditions. Next slide, please. So this is also taken from the same the SPIC tool. So if it's heart disease, as I said before, it can be an NIHA class 3 or 4 heart failure, extensive untreatable coronary artery disease, or severe inoperable or peripheral vascular disease. Next slide, please. If it's liver disease, it's an advanced cirrhosis with a diuretic resistant ascites or ascites requiring recurrent drainage, hepatic encephalopathy, hepatorenal syndrome, all the complications of the liver disease, bacterial peritonitis and recurrent varicose bleeds. Next slide, please. And if it's kidney disease, it's stage 4 or 5 kidney disease, kidney failure complicating with other life-limiting conditions, stopping dialysis, and advanced diabetes, unresponsive treatment with deteriorating health, including a kidney failure. Next slide, please. So what is the recommendation? Is that access to palliative care should be based on the need rather than the diagnosis. So it comes back to the point that I started mentioning. It's all about the serious health-related suffering, the suffering of the patient at whatever diagnosis they have and whatever point in the diagnosis. And this is a surprise question that I was talking to you about. The strong recommendation is offering palliative care to anyone who in the probability is likely to die within the next 12 months. The surprise question is, would I be surprised if the patient is died in the next 12 months? If I look at a patient who comes to my OPD and then thinks in my mind that, will I be surprised if this patient dies in the next 12 months? And if I'm not surprised if the patient dies in the next 12 months, then he definitely requires palliative care now. That is a surprise question that is useful to refer them. Next slide. So to conclude, palliative care is needed for all the patients with a serious health-related suffering, which includes cancer and non-cancer. We still need to do a lot of research into the needs assessment tool for specific conditions, and also the benefit for the evidence to try and move evidence for benefits of palliative care involvement. Thank you.
Thank you, Dr. Sunitha. Although we lost you in between. Thank you for that elaborate presentation, because you have covered almost all the disease conditions that we see regularly. And there are a lot of questions we come across very often, that whether this patient needs palliative care. So there was a clear answer for almost all the disease conditions that we encounter. I would like to hear from the participants. Is there any questions, or at least did you learn something new? I think that is the easiest question to answer. If so, what did you learn? I learned a lot of new things from today's sessions. I hope you might have learned.
Dr. Ellis?
I also learned a lot of things. Mainly, I had the idea palliative care is more for the cancer patients. Now I come to the conclusion that that
Also.
Lily Thomas.
Thank you, ma'am. Dr. Lily Thomas?
Yes, ma'am. That for the COPD patients also we can give the palliative care treatment.
Yes, definitely.
COPD patients.
Oh yeah, that was the first one that eye disease I covered. COPD definitely needs palliative care as early as possible because they've got the maximum, they've got more symptoms of breathlessness than the cancer patients. So, and I think non-pharmacological management of breathlessness is a developing field. Lots of research happening, and there's lots that we can do as a palliative care doctor for COPD patients. Yeah.
Thank you, Dr. Lily Thomas. Any other questions or your experience with a patient with non-cancerous? Yes, Dr. Annie. Yes.
Yeah. See, there are some patients who are neurologically deteriorating and they are not able to give any consent except to prepare them for end of life care. So I see patients for many months and even years. Like our own sisters, some of them are there who are not able to give any consent. But of course, they are taken care well. So when we say the total care or end of life care, how to prepare them, we don't know. That's my question.
Yeah, that's again, there's a lot of what I find different in practicing in India and practicing in UK is this question about patient autonomy and patient involvement. So if you work in UK, you realize that whatever disease a patient has got, our first point of contact would be the patient. So we tell the patient everything. This is cancer and non-cancer, and then the family gets involved. So obviously they come to the GP first diagnosis. So the question about advanced care planning and making advanced directives before they lose the capacity to make a decision. So all those happens before that, and they're encouraged to document what they want to do in case when they lose capacity. So then you can't take a consent, and we have conversations like that, before they lose the capacity. So they write it down. They say they want antibiotics or not antibiotics, and they can give power of attorney and things like that, to make up for the next of kin to carry out the decides. And that's all happen in the Western world. Here, what happens is, even without all that, usually if it's a cancer patient, also we don't normally have the conversation with the patient first, and we always speak with the family first, and that's culturally what happens here. And sometimes the family doesn't want to speak to the patient, and we sort of sometimes respect that, even though I tend to tell that if the patient asks me something, I wouldn't allow it to the patient. So it's always, I'm sure I haven't had much end of conversation with the patient, even though they haven't lots of capacity. We don't normally have that conversation. So that is something that needs to be changed culturally here. And if ideal situation, before they lose the capacity to make a decision, we should be telling them this is going to happen in your future with your diagnosis. And if this happens, do you want to be connected to a ventilator? Do you want to get IV antibiotics? Do you want to have a PEG tube or a feeding tube put in? All this should be discussed before they lose capacity and written down, so that we can respect the wishes.
Thank you, Dr. Annie, and thank you, Dr. Sunitha. So any more questions? Like you can raise your hand or unmute yourself and speak. Yes, Dr. Vinay.
As I heard from Dr. Sunitha, I think all people, all human beings need is the palliative care at one stage or another.
Very, very true. Yes. Yes, ma'am. That's very, very true.
Dr. Vinaya?
Yeah.
Yes.
We had a staff who was just a 41-year-old, 2 children, who is unmarried. Elder one is 18 years, younger one is 14 years. And then she had oral ulcers. We went into chronicity and she was taken to government hospital, and they were not able to diagnose her disease. And she had given, I think, some chemotherapy agents. She was feeling much better. And then again it recurred, and she went into, within no time, maybe within 3 months to 4 months, she died. For us, it was a very painful experience. Plus, I was not able to make her understand or communicate with her or tell her, because I was not sure. I was each time expecting that she will recover and come back. She will recover and come back. Now, since 1 month back, she died, and her daughter is now with us, 18-year-old. I kept her here with us so that she is able to study and do something in the hospital that she can earn her living. Her husband left her since 2-3 years back. No contact with him at all. But her PF and all her other pays, because she was not prepared, so her automatically it will go to her husband and not to the children, plus to the children and the husband. If the husband does not give a consent, nothing will get, the children will not get anything. So we were feeling very bad, and I was listening to these talks, and especially today's, I was thinking, if I had ever thought that she wouldn't live for another few more months, we could have prepared her, and then all this would not have happened. So it is a big, we are not able to tell exactly for 6 months they would live or not live, especially non-cancer.
Yeah, that's very true, doctor, and thanks, really thanks for sharing that. I also, it's very, very important for us to know, as an individual, to know what I'm facing, and how my life is going to be. And sometimes, when I've got we have this difficult conversation with the family, when they try to, just protect their family or prevent their father or mother to know that they've got a cancer diagnosis, and I keep sort of tell the family that actually it's their life, and they should know that they've got a life-threatening diagnosis. They've got plans to make. They have to decide on the future. They might have in hopes and dreams to do before they die, and which we are actually not giving them opportunity to do then, because we're not telling them they've got a cancer diagnosis, and we're we're not giving them the chance. So I think it's very, very important. It's not just as doctors, it's as people, for us to know that it's our community and our citizens. So basically, if I had a diagnosis like this, I should be able to know. So then my mother also has a right to know about diagnosis. That sort of feeling should come to everybody. Culturally also, change has to come.
Sridevi ma'am, I think Dr. Sunitha,
Yeah.
lost Dr. Sunitha.
Yeah, I heard. I think I lost in between, but I heard a little bit. I heard half of the story. So are we proceeding with the discussion points, or
I
sorry,
think we have
I lost my
Dr. Jyoti. Dr. Jyoti, you had a question in between, ma'am?
There were discussion points. I don't know whether they have been discussed, the concerns.
No, ma'am, the points are not been discussed yet. Before, we had a question from Dr. Jyoti.
Question.
Dr. Jyoti, are you there?
Yes, ma'am. Yes, ma'am.
You were about to ask something, ma'am?
Yes, yes. I was asking, we spoke about the depression patient, palliative care for this patient, but what about psychotic patients, for palliative care for psychotic patients?
Yeah, ma'am. As I mentioned, I haven't covered everything of non-cancer conditions. So, psychotic and delirium, terminalization, all these do come in palliative care. So it's not the we could actually be involved with patients who's had has a diagnosis of bipolar disorder or psychotic diagnosis, and then we have to get involved. Because they've got a cancer diagnosis, we might get involved. So important thing to realize is if you can't manage all the medications, obviously get the psychiatrist also involved. There'll be a lot of polypharmacy involved. There'll be interactions and medications that we start. But the important thing to remember is not to stop anything. That's already been started. If the patient has a psychotic episode while under care, which is a new episode, then try to find the cause of that, get the psychiatrist involved. But delirium causing psychosis, normally the general advice is dementia patient or delirium patient having psychosis, general advices would be to provide one care and specialist care, and not to give them any sort of antipsychotics or sedatives unless it's indicated. So unless they are harmful to self or harmful to the others, then we give things like haloperidol, quetiapine, olanzapine, and obviously benzodiazepine to sedate them. But I haven't covered everything, so yeah.
Okay, thank you, ma'am.
Thank you, Dr. Sunitha. Can we move on to the discussion points? There are 3 discussion points and we have only, I think, 10 minutes left.
Yep.
So can we take one by one?
I've just shared one paper with you, Rajashmi. If you can put that up, because that is a CME on renal disease. So the first question is renal failure when they are unable to go for dialysis due to financial problem. What can be done? This is similar to the study that I mentioned in between, right? So there's a conservative group and the dialysis group. So this, if you can put that CME paper up and you can share it with them, it actually shows, what are the steps, what can you do and everything. Have you got that?
Yes, ma'am, I have received it, so I can share it along with the learning materials to all.
Yeah, okay. If you can, yeah, fine, that's fine then. Because if you can put that on the screen now, it actually says step by step about what to do. That's possible. Because I can't do it.
Yeah, I think that can be done, right, Raju?
1 second, ma'am. Let me check.
Yeah.
So,
meanwhile, Raju is checking. Can we move on to the next question by the time Raju is projecting the document?
Sure, ma'am.
Preparing for end-of-life care. I think a little bit you mentioned in the previous question, preparing for end-of-life care when it comes to chronic illness, non-cancer illness, how difficult it can be when it comes to prognostication.
Yeah.
Yeah. So any more points to be discussed?
So what they say is once they're established on dialysis, and I think this patient lived for 2 months, I think, isn't it? But technically, the average they will survive is actually 8 to 10 days only. Once they're established in dialysis and you stop the dialysis due to any reason, the average they live is 8 to 10 days. The guideline clearly says that before you stop the dialysis, you start the advanced care planning and tell them, or the family, that the patient might be dying pretty quickly because all the hemodynamic changes happens. Again, depending on if it's a poor urine output dialysis, definitely they're going to go into pulmonary edema and all, right? So they might die pretty quickly. Then hyperkalemia. So the advanced care planning is very important, and needs the symptoms. We might not be, if it's an intractable hyperkalemia, we're not going to do the bloods all the time and treat the hyperkalemia all the episode, because they're going to, it's not a reversible condition, right? So it's having that conversation with the family about this is going to happen like this and how are we going to manage. They're going to be dyspneic, so you're going to give them morphine or whatever that's renally safe. So you have to go with fentanyl most probably, because they're in stage renal failure. So you're going to give them opioids, you're going to give them sedatives and sort of sedate them and prepare for the end of life care.
Thank you so much, Dr. Sunitha. Raju, do you have that document now?
Yes, ma'am. I'm sharing it now.
Okay.
So if you look at that, it's a CME in palliative medicine, palliative end of life care. So if you scroll down, prescribing, initially it's about prescribing. If you come down, symptom control, advanced disease, come down. So that's conservative management for end-stage renal failure. So that's a chart. So it clearly says what do you do if there's no dialysis, what all input that is needed. So basically just tells us how to do an MDT management of the patient. They go into routes and what all. It's about diet, anemia management, vitamin D and phosphate, checking the levels. So fatigue will be the main problem. So manage in anemia manage is very important. Diet is important. Then managing all the symptoms, uremic symptoms can come, then itch can come, pain can come. So all this we need to think of because they're not going the dialysis route. And obviously, if it's a poor output, then pulmonary edema can come. Try diuretics so that will the work or not, we don't know. So all this need to be thought about, and obviously advanced care planning. If you can go through this, Rajlakshmi will email it to you. It clearly says what all should we do, and once they reach end of life, then what do you do at that point?
Yeah, thank you so much. I think that document will be shared so everyone can go through it. And I think there are many slides in which Dr. Sunitha has pointed out the references. So I think going on through that journals will be really helpful. Any other questions from? I can't see anyone. I just hear you. So questions from the other participants.
Yeah, the last question was how can we convince our relatives of home-based care? That is going to be the tricky part, isn't it? Because we have to tell them that there's no point in taking the patient to hospital, because if you take them to hospital, if it's a private hospital, they're going to end up putting in a ventilator, which is not the appropriate care for. So it is telling the next of kin, then telling the entire family that they're doing the right thing. We can manage things at home. We can keep them comfortable at home, but that is going to be a very, very huge task, and it's making the family understand that they're doing the right thing also, that they're not giving up on their mother, but they're doing the best care for her.
Raju, any other questions? I'm totally blank about if there anyone has any questions.
If there is any more questions or doubt, you can raise your hand or unmute yourself and speak. Dr. Jyoti, you wish to add something or ask about the patient story?
Yes. I had taken this case because the patient for my presentation after help. Am I audible?
Yes, doctor, you can speak.
Yeah, because during my stay in this hospital, I saw about 10 to 12 young patients dying in front of me with renal failure in their 20s and 30s. They started on dialysis outside and they come back and they are not unable to go for further dialysis and they die. So I was feeling very sad about it, what I could have done for these people. So that's why I took this patient. This patient is 50 years, but others were in their 30s and in their 20s.
In Andhra Pradesh, there are schemes for these kind of patients, renal failure patients. Government is giving the schemes for dialysis, and there are some centers. And also Arogyasri, that also wherever there is Arogyasri, they can get it free. I don't know, we have to also approach the government, I think, because we can't give them the free dialysis.
Okay, yeah, but I have a question in that point, because it's not just about the finance, it's about the incurability and how long will you keep providing financial support and how long they'll have to undergo the dialysis. I think Dr. Sunitha would better speak about it.
Yeah, I think that's very true, Sridevi, because ultimately all these patients will need a renal transplant, isn't it? Because you can't just go on putting them on dialysis. Similar with the liver also, like liver patients also, like when they reach an end stage, the transplant is the next question. So, putting them on, like young patients, 20, 30, how long you can do that for? How long are you going to support it? It's not a long-term option. So, but then that's a very, very difficult scenario to actually discuss, isn't it, today? Because how do you discuss a conservative option for a 30-year-old patient? It's okay to do it on a 70 or 80-year-old, but I think doing it on a 30-year-old is going to be very, very challenging. But yeah, we need to think of everything.
Yeah, that's true. I just wanted to convey that it's not just the finance always the problem when dealing with the chronic renal failure or any other non-cancer illness. Sometimes it's the incurability is the issue, and the time for starting the conversation is also important. That we need to have a clarity whether we actually need to talk about it. Yeah. Any other question, Raju, before winding up? We have just maybe one more question. It's 4:30.
No hands are coming up, ma'am.
Okay, then you can conclude. I can't see anything.
Okay, thank you. Thank you, Dr. Sunitha. Thank you, Dr. Sunitha, for taking a wonderful session for us. So we will see you on next week also with this topic on gastrointestinal symptoms. So thank you all for joining in.